really diagnose systemic disease through looking at oral pathology. The question is, in the literature, I think it would be beautiful if now you looked at it the other way and explored the role of treatment of cardiovascular risk factors in improving oral outcomes. So there's been early work with inflammation. What about looking at treatment with statins, lowering lipids, and looking at treatment other that way, and how it coordinates with really the two-way street of maybe treating systemic disease to also improve oral outcomes. One of the questions I know is going to come up is, looking at all this, should I be getting CRP on all my patients? And I think the answer is likely not. And the reason is that in very low-risk patients, it's not going to help. Very high-risk patients, they're already high risk, it's not going to help. But in the group of patients that you might see with, again, these metabolic risk factors, it may not be unreasonable in selective patients to look at it and see if it's something that is of a potential interest, because when you have someone who's in the moderate risk class, knowing that have a high CRP essentially moves them from the moderate to the high risk class. So in summary, I think there's a lot to do. The data is tantalizing, and I think given now the awareness of this, hopefully in a few short years we'll have more data to come and talk to you about. So thank you very much.
Thank you, Dr. Zarich, very much. Our final speaker this morning is Dr. Michael McGuire. Everybody in this room knows Mike, so we'll keep his introduction short. He's a former president of the AAP. He has a very active clinical practice in Houston, Texas, where he does a lot of clinical research, and is also an adjunct professor at the University of Texas Health Science Center in San Antonio, as well as in Houston. So, Dr. McGuire.
Thank you. Thank you, Brian, and thank you, everyone. It's always an honor to have the opportunity to present at the AAP annual meeting. I think Dr. Williams has done his usual elegant job at bringing us up to speed on where we are with the periosystemic connection, and I've learned a lot about inflammation as it relates to systemic health from Dr. Zarich. My job here as a clinician is to basically say, so what? What does the movement from an infection model to an inflammation model of disease change the way we treat our patients? Does it or should it change the way we do daily activities in our practice? And I can tell you, as I began this process, if I took a hard clinical stance and I looked at my practice, the answer was no. That this change of inflammation emphasis had really not changed the way that I treat my patients on a daily basis, the way I diagnose my patients, the way I maintain my patients. And of course, that begs the question, well, should it? And I can tell you that I've struggled with this question for almost 2 years since I accepted this speaking engagement. And over the last 6 to 8 months, as I've actively researched this topic in preparation for this, I probably have worked harder on this lecture than I have anything in recent past, because really this isn't my area. Unlike the two gentlemen preceding me, I'm not an expert on inflammation, and I'm certainly not going to stand up here and talk to you about CRP levels, IL-1, IL-6, TNF-alpha levels. I'll admit I didn't even understand all of the things that the previous two speakers talked about. But I don't think as clinicians we really have to understand the molecular level of inflammation. I think as a clinician I can recognize inflammation in my patients. I think when I do the things I've been taught as a diagnostician and as a clinician, I'm pretty good at resolving inflammation. I think on most of my patients the outcome's fairly good. But our job as a clinician is to try to synthesize, try to translate all this research and bring it into practice. So what I'm prepared to do with you this morning is just simply to share my journey with you over the last 6 to 8 months as I have re-looked at the literature on inflammation, as I have talked to experts on inflammation across the world to see whether or not maybe I've missed something. Maybe there's something I should be doing different in my practice today than I've done in the past. Note I said I should be. At the end of the day, you're going to have to decide, should you be making any different decisions? Now, as I began this process of re-looking at inflammation, I have now a better understanding why so many of the experts on inflammation say, hey, forget the bacteria, control, or even better yet, prevent inflammation. This problem of out-of-control inflammation seems to be the engine that's driving the ever-growing list of chronic systemic diseases. And the problem of inflammation's friendly fire and systemic consequences is nowhere better illustrated than in chronic periodontitis, where we have a bacterial assault, but at least 2/3 of the tissue destruction is mediated by the host response to the bacterial invader, and to make matters worse, it seems that somehow this can affect things systemically. So the question remains, how should our new knowledge about inflammation relate to the treatment of periodontitis patients today and in the future? Note how I've emphasized today. You know, the easy way for me to have kind of skirted this whole issue was for me to give you a lecture on the future. You can't hold my feet to the fire if I do that, because I could speculate on all sorts of things, and frankly, the future is very bright as it comes to the control of inflammation, as it may relate to the treatment of periodontitis, regeneration, and all sorts of things. But as a clinician, I didn't think that would really give me too much. You know, I want to look at what's going to be important when we return to our practices at the end of next week. So we'll talk a little bit about the future, but I want to very much try to ground our conversations this morning in what we know today. So I re-looked at the literature, I talked to experts on inflammation around the world, and I basically focused on the following questions. How should inflammation fit into risk assessment? Is there a way to identify hyperresponders, and if so, should these patients be treated differently in our practice? Should new knowledge about inflammation change routine clinical decision making? Yes, no, sometimes. How should we do that? Should we change our patient examination? Are there any diagnostic markers for inflammation that are ready for use today? Should we spend more time on review of systems in our medical history? Is there a greater role for drugs, either local or systemic, that modulate the inflammatory response in the treatment of periodontitis, either antimicrobial or anti-inflammatory agents? Same question as it relates to regenerative therapy. I don't want to just look at treatment of disease, but how about regeneration? Should new knowledge about inflammation change the way we maintain our patients? Is there a greater role for drugs, both local and systemic? And how about all those questionable teeth that we're maintaining? And finally, are periodontists at risk for not referring patients who have other chronic inflammatory conditions to physicians? So I looked at all those questions. I restudied the evidence, and you know, basically what I found at the end of the day was that it really still didn't change a lot of the things that I'm doing. That good periodontal therapy is good periodontal therapy, but it did make me think about a couple of things, and that's what I'm going to share with you. Well, let's go to our first question. How does inflammation fit into risk assessment? You know, I'm certain that you're just like me in that you really don't have any generic patients. Everybody in your practice responds differently to inflammation. Everybody in your practice responds different to therapy. It'd be nice if we had a way to differentiate how are these people going to respond. Are they going to have mild, moderate, or severe response as far as their inflammatory reaction to local etiologic factors? For example, this patient in my office, she has fairly severe local etiologic factors, but not much of an inflammatory response. It'd be nice for me to be able to predict that. On the other end of the spectrum is this young man. This is a 24-year-old young man who's in my practice who has severe aggressive periodontitis. You know, both the opportunity and the challenge to us is to be able to identify this person early so they can be referred to a periodontist, treated appropriately, and maintained. But unfortunately, the way we generally identify these people is when they're at this stage. Is there a way for us today to be able to determine that this is a hyperinflammatory, he has a pro-inflammatory phenotype? You know, as periodontists, we're taught to evaluate the outward signs of inflammation. You and I look at bleeding on probing, we look at tissue changes, when in reality we're really looking at vascular proliferation, edema, tissue fragility. We look at probing depths, attachment levels. Really, we're looking at surrogate markers for connective tissue changes in the inflammatory phase of the wound healing process. We're taught to correlate infection, inflammation, and clinical presentation as we look at our patients. But the problem is, these don't always correlate. For example, you can have infection with certain microbes that don't really give you a clinical sign of inflammation. Ichinella corrodens, for example, rarely will give you any signs clinically that you're having any inflammation. Now, you can look at it on the lab bench with biochemical markers and tell that, but it doesn't give the clinical presentation. So there's a missing piece to the puzzle here. That was certainly one of the take-home messages in our series of articles on prognosis that we wrote. That, if you're looking at commonly taught clinical parameters, they're not very good at predicting prognosis or the survival of the teeth. And in fact, they're even worse predictors in severe disease. Why might that be? Well, because you're somehow not bringing the host into the evaluation. There are novel diagnostic tests that allow you to determine if the patient has an IL-1 genotype that will cause the patient to over-respond to plaque. But our studies and many other studies have shown that even that doesn't tell the whole story. But that's not surprising, because if you look at all the genetics right now, genetic testing, that it's at an early stage. Not only an early stage in development, but also an early stage with what do you do with the information once you have it. I think that's one of the things that all of us struggled with. Now, that doesn't mean it's not important. Certainly, genetics plays a big role in why some of us respond with a lot of inflammation to plaque and why others, the inflammation goes away fairly quickly. But it's a complex story, and probably it's going to involve 3 to 5 gene families. It's going to depend on what ethnic group you're in, and clinical expression will probably depend a lot on lifestyle decisions. But the European workshop concluded that to date there's no clear correlation between any gene polymorphism and clinical indicator of inflammation. Well, there are a few computerized systems that may be of use that help us quantify disease status and risk. It's not that they really allow us to pick up hyper-responders, but again, as I said a moment ago, one of the ways that we really have determined pro-inflammatory patients is the fact they don't respond to traditional therapy. So perhaps if we have computerized assessment tools, we'll be able to pick these patients up a little earlier and not have to wait till they've gone so far down the road of disease before we determine that this is not somebody that we're going to treat in a typical fashion. So to answer our question, is there a way to identify hyper-responders today in clinical practice? No. The future's bright. With genome assessment studies, we are going to have wonderful new diagnostic tools, I'm absolutely convinced. We're going to have relevant biomarkers that we can use with saliva, with oral fluids that are going to give us real-time assessments of our patients' inflammatory status, allow us to treat these patients appropriately and earlier. But when it comes to today, as far as diagnostics, there's nothing that we can use chairside. Well, if we're not going to change our diagnosis much, how about, is there a greater role for drugs, either local or systemic, that modulate the inflammatory response in the treatment of periodontitis? We've got tons of evidence out there saying that we treat these people pretty good. Traditional periodontal therapy is effective in mild to moderate cases. It's these folks that you and I can effectively treat and hold our heads up high. Treatment for these type of folks have really not changed over the last 30, 40 years. I treated this patient in my residency 30 years ago with root plane and scaling and improving home care, and I'd probably do it the very same way today. Periodontitis is a bacterial-induced inflammatory disease, and our treatment today continues to focus both in treatment and maintenance on microbial control. It's these folks that we have a problem with. We've already established that we still don't have a way to be able to identify them early. How about treatment? The good news is they only occur in a small subset of the population. The bad news is all the people that we can treat effectively are typically being held in the general practice. So we're not seeing the ones that we can treat easily nearly as much as we used to, and this group is becoming proportionally larger group of our disease treatment and our periodontal practices. Now, what do we know about treating these patients that have aggressive disease? We know that if you're going to treat these people, we have to center on all the three elements that are driving tissue destruction: bacterial infection, the inflammatory cascade, and the host response. There's some evidence to suggest that with aggressive periodontitis, you also have systemic inflammation. That if you have just the bacterial assault and no systemic inflammation, you're probably going to end up with mild to moderate disease. But if you have the bacterial infection and you have a systemic inflammation, there is a synergistic destruction that drives the disease further than it would otherwise. And with that's one of the reasons why we commonly see severe disease associated with other chronic inflammatory diseases: pancreatitis, osteoporosis, the whole list that Dr. Williams and Dr. Zarek have been talking about. And in order to treat these people effectively, we also may need to bring as much as we can under control the systemic inflammation. It's another reason why we have to treat these people aggressively, not only because of the severe disease, but also because of the systemic consequence of not treating the disease. Now, to manage the bacterial infection, we'll do that the way we have always traditionally done, and that's with debridement. But when you have patients that are overreacting with inflammation to the bacteria, perhaps we need to be more aggressive with our mechanical debridement and reduction of probing depths to reduce this entire bacterial load in the periodontal pocket and in the entire oral environment to make that patient more maintainable. And along with that, if they're not responding well, as generally these patients won't, we want to consider antimicrobial therapy as needed with subgingival or systemic antimicrobials. Now, we know that with mechanical debridement, we can greatly reduce the bacterial load in the oral environment. But if you look at repopulation kinetics, the bacteria comes back pretty quick. We know also if we will add to our mechanical debridement either local or systemic antibiotics, we may be more effective at maintaining that reduction in the bacterial load. And so especially with patients that have a systemic inflammation, the antibiotics may be important. You know, that's one of the things that Tanetti in his paper showed, that with root planing and scaling and locally applied antibiotics, they had a lower amount of systemic inflammation than they did just with the debridement itself. And then management of the host. Now, this is a sticking point because we've known for a long time that host plays a big role. You know, in my residency in the mid-70s, plaque was plaque and too much of it was bad. And from that, we moved to kind of the Bug of the Month Club where, you know, it was certain bacteria that was causing certain diseases. And after that, we began to say, hey, you know, the host may be playing a role here. So we've known it for a long time, but the catch has been, how do you manage it? How can you control it? Many people have made great strides at doing just that. Dr. Williams and his group have shown that they can halt the progression of periodontitis with anti-inflammatory agents. Unfortunately, the drugs are almost worse than the disease, but proof of principle was there. Lauren Golub and his group coined the term host modulation in the 90s, and the work continues. If we look at the state-of-the-art summaries, what do we have? This comes from the European Federation State-of-the-Art Summary in 2005. Clinical trials have demonstrated the ability of non-steroidal anti-inflammatory drugs to slow periodontal disease progression. However, recently reported serious adverse events preclude the use of COX-2 inhibitors as adjuncts to periodontal treatment. Adjunctive use of subantimicrobial dose doxycycline to non-surgical periodontal therapy is beneficial to the management of periodontitis over 12 months. Controversial data exists on the effects of bisphosphonate administration as an adjunct to periodontal therapy. and evidence on modulation of other host mediators, including lipoxins, cytokines, nitric oxide synthesis, is limited to animal research. And they conclude, after validation in long-term clinical trials, adjunctive host modulation therapy may prove advantageous in the management of periodontal disease. Well, you know, maybe that's just what's going on the left side of the Atlantic. Maybe we have something more to manage the host in the United States. Well, let's look at the consensus statements of the AAP. Since destruction of the periodontium is believed to be due to the host response, it's logical to consider therapeutic approaches that modulate host response in addition to antimicrobial, antibacterial approaches in the management of chronic periodontitis. 3 potential approaches to host modulation have been considered: inhibitions of MMPs with antiproteinases, blocking production of pro-inflammatory cytokines and prostaglandins with anti-inflammatory agents, and inhibiting activation of osteoblasts with bone-sparing agents. And after a large systematic review, they conclude large multi-center trials are needed to evaluate the role of host modulating agents in the treatment of periodontal disease. That sounds familiar. NSAIDs and bisphosphonate drugs may have potential adjunctive role in periodontal treatment, and the adjunctive use of sub-antimicrobial dose doxycycline with SRP is statistically more effective than SRP alone in reducing